So when a red warning light flashes on your dashboard, you pull over, right? I mean, the signal is pretty binary.
Right, yeah.
The engine is either fine or the car is explicitly telling you something is critically broken. And we tend to treat the human body the exact same way, especially in medical emergencies. We look for those obvious flashing lights like a sudden drop in blood pressure.
But in the world of critical care and trauma, waiting for that specific dashboard light to diagnose shock means you are already dangerously late to the party.
Exactly. So today, we're diving into a stack of clinical medicine and nursing sources to completely rewire how you think about human survival. Our mission for this deep dive is to break down the four types of shock, the warning signs that honestly trick even seasoned medical professionals, and how the field's understanding has evolved.
Right, from, 18th century battlefields to modern ICU protocols. And for those of you listening, whether you're managing patients clinically or just fascinated by how the human body triages itself in an absolute catastrophe, I mean, this changes everything.
It really does.
Recognizing shock early within that vital window we call the golden hour dictates life or death decisions globally. The protocols we're unpacking today are the literal foundation of triage.
Applied everywhere from a local trauma bay to an active battlefield. But to start, we really have to throw out the dictionary definition, don't we?
Oh, absolutely.
Because the general public equates medical shock with, well, a sudden drop in blood pressure. It's so deeply ingrained in pop culture. A patient crashes, the monitor's alarm because the pressure plummets, and someone yells that they're in shock.
Which is a fundamental misunderstanding of the physiology. Shock is not a macroscopic blood pressure problem. It's a microscopic cellular and metabolic crisis.
Make that distinction for us.
Sure, so the clinical definition is a state of inadequate tissue perfusion.
Hmm.
Basically, the delivery of oxygen and nutrients to the cells has simply failed to meet the body's demands.
So the cells are suffocating on a systemic level.
Exactly, they're starving for oxygen. And when that delivery fails, your cells don't just stop working, they're forced into anaerobic metabolism just to survive.
Which is super inefficient, right?
Highly inefficient. It generates only a fraction of the necessary energy and produces dangerous byproducts, specifically lactic acid. Uncorrected, that mounting acidosis causes progressive cellular injury, cascading into multiple organ failure and eventually death.
Wow.
Yeah, the crisis is happening at the cellular level long before it ever registers on a standard vital sign monitor.
So waiting for low blood pressure, then, is literally waiting for the engine block to melt and seize up before realizing you have an oil leak. The blood pressure drop is just the final catastrophic system failure.
That's a great way to put it. Because the human body is built with incredibly robust compensatory mechanisms to keep that dashboard light off for as long as possible.
Yeah.
We categorize shock into three progressive stages based on those defenses.
Okay, let's walk through those.
The first is compensated shock. Your tissues are already starving, but the body fires up the sympathetic nervous system, flooding the system with catecholamines like epinephrine and norepinephrine.
And this triggers massive vasoconstriction and tachycardia, right? Just desperately trying to maintain that systemic blood pressure by any means necessary.
Yeah, the body is ruthlessly triaging its own blood supply. It clamps down the vessels in the skin, the gut, the kidneys, forcefully shunting whatever oxygen is left to the brain and the heart. So the vital signs might look perfectly stable.
But the invisible fire is already burning. And if the underlying cause isn't fixed, you inevitably hit the second stage, which is decompensated shock.
Right. The compensatory mechanisms are finally exhausted. The vascular tone gives out, the heart can no longer maintain the extreme pace, and, well, this is the moment the blood pressure actually crashes.
And the third stage is basically the point of no return.
Irreversible shock. The cellular damage and acidosis have progressed so far that even if you resolve the initial insult, say you surgically stop the bleeding or unblock the coronary artery, the cascading organ failure just can't be stopped.
Death is imminent.
Yeah, it is.
Which really reframes the entire approach to critical care. It explains why ICU teams are constantly hunting for what the sources refer to as occult or cryptic shock. They're looking for the metabolic smoke before the vital signs crash.
Exactly. Clinicians have to look for earlier, far more sensitive markers of poor perfusion. They're drawing blood to check for elevated lactate levels to catch that anaerobic shift. They monitor capillary refill times and watch for, sudden drops in urine output or a subtle altered mental status. You have to actively hunt for it.
I want to pivot to the history here because
Yeah.
this concept of hunting for microscopic cellular suffocation is actually relatively new. For centuries, the medical field was flying completely blind on this. The
Oh.
term itself didn't even originate in a physiology lab.
No, it didn't. It originated in the trauma of warfare. We trace it back to around 1743 to a French surgeon named Henri-François Ledron.
Right.
He was treating devastating gunshot and cannon wounds, and he used the term shock to describe the violent physical jolt of the projectile impacting the human body.
And then, across the English Channel around 1815, when surgeon Samuel Latham translated Ledran's work, bringing shock into the medical lexicon. But looking at the sources, the meaning started to drift over time.
It did. It shifted from the literal physical impact of the bullet to the mysterious physiological collapse that sometimes followed hours later. But nobody really understood the mechanism.
Yeah, I love this quote from the sources. In 1872, the prominent American surgeon Samuel Gross described shock as, get this, a manifestation of the rude unhinging of the machinery of life.
It's so poetic. But as a clinical diagnosis, it is entirely useless. You cannot push a specific IV medication to fix a rude unhinging.
Right. Nurse, push 50 cc's of unhinging reversal. It doesn't work.
Exactly. And that lack of mechanistic clarity fueled intense rivalries well into the early 20th century. During World War I, the sheer volume of crush injuries in the trenches led a physiologist named Walter Cannon to popularize the toxic theory.
His logic actually makes a weird kind of sense if you put yourself in a 1918 trench. You have a soldier with a crushed limb, maybe a tourniquet applied. When the tourniquet comes off, the soldier suddenly crashes and dies.
Right. So Cannon argued that the dying crushed tissue was releasing some kind of unknown poison or toxin into the bloodstream, triggering circulatory collapse.
But he was wrong.
He was. It was an elegant theory, but fundamentally incorrect. The true breakthrough required rigorous experimentation, which American surgeon Alfred Blalock undertook in the 1930s.
This is the same Blalock famous for the Blalock-Taussig shunt in pediatric heart surgery, isn't it?
The very same. Before his pediatric cardiac work, he systematically studied traumatized tissues in animal models. He meticulously measured the weight of injured limbs versus uninjured limbs, quantifying the exact volume of plasma and fluid shifting into the damaged tissues.
So he was literally weighing the fluid loss.
Yes, and he proved conclusively that circulatory collapse wasn't caused by a mysterious circulating toxin. It was caused by massive fluid loss out of the vascular space and into the surrounding tissues. The blood volume was simply plummeting.
He proved it was a volume and flow problem. The plumbing was failing.
Blalock proposed a categorical system in 1934 that heavily influenced our modern approach. But it was Max Harry Weil in the 1960s and 70s who finalized the modern framework by shifting the focus entirely to the actual mechanism of cellular suffocation oxygen delivery.
And this brings us to the core of the sources, the absolute mathematical foundation of this deep dive. Weil's focus gives us a literal equation for human survival. When the variables in this equation break, you get the four modern types of shock.
Right. It is the oxygen delivery equation, or DO2. The formula is cardiac output multiplied by arterial oxygen content. Essentially, how much blood is the heart moving to a minute, multiplied by how much oxygen is actually bound to the hemoglobin in that blood.
And cardiac output itself is just heart rate multiplied by stroke volume.
Yes. And stroke volume is where the plumbing mechanics become essential. Stroke volume relies on three specific variables: preload, contractility, and afterload.
Let me make sure I have this straight. Preload is the tank volume, like how much blood is actually returning to the heart to stretch the ventricles before the next squeeze.
Spot on.
Contractility is the pump, the inherent physical strength of the heart muscle. And afterload is the resistance in the pipes, the systemic vascular tone the heart has to push against to eject the blood. So tank, pump, pipes.
Exactly. Tank, pump, pipes. Every type of shock we treat today is simply a pathological failure of one of those specific variables. Let's apply this to the four categories. Wheel helps cement, starting with the most intuitive one.
Hypovolemic shock. This is a catastrophic failure of preload.
The tank is empty. There's an absolute loss of circulating blood or fluid volume, meaning there is simply not enough volume returning to the heart. Stroke volume drops, cardiac output plummets, and oxygen delivery fails.
The classic scenario is severe trauma and hemorrhage. And the sources dive into the advanced trauma life support, or ATLS, hemorrhage classifications, and the data perfectly illustrates our earlier point about compensated shock hiding the danger.
Oh, the ATLS classes clearly outline how deceptive the human body can be. You can have a healthy young trauma patient lose 30 to 40% of their entire circulating blood volume a class 3 hemorrhage, and they will often maintain a completely normal blood pressure.
Wait, almost half of their blood is on the floor, but the monitor looks fine.
Because their vasoconstriction reserves are so robust, the body clamps down the pipe so aggressively that it masks the empty tank.
Yeah.
But they are hanging by a thread. The second those sympathetic reserves fail, they instantly crash into a class 4 emergency and the mortality rate skyrockets.
It's totally the Wile E. Coyote effect. He runs off the edge of the cliff and continues sprinting in midair, defying gravity. Everything seems fine until he looks down, the illusion breaks, and he plummets.
That's a perfect analogy. If you were waiting for the BP to drop, you were watching him fall.
Okay, let's move to the second failure point. If hypovolemic is an empty tank, what happens if the tank is completely full, but the oxygen still isn't reaching the tissues?
Then the problem is the pump itself. This is cardiogenic shock, a failure of contractility. The intravascular volume is adequate, but the myocardium, the heart muscle, is too damaged to generate an effective forward squeeze.
And the most common trigger here is an acute myocardial infarction, right? A massive heart attack.
Yeah. The mortality associated with cardiogenic shock is historically brutal, sometimes reaching 80% in earlier decades. The turning point was the landmark 1999 SHOCK trial.
What does that show?
It demonstrated that rather than just trying to medically stabilize these patients with drugs, aggressively pursuing early revascularization, so rushing them to a cath lab or surgery to physically unblock the coronary artery, significantly improved survival.
You have to restore blood flow to the dying pump muscle immediately. But even with modern cath labs, the sources indicate the mortality rate for cardiogenic shock still hovers around 40 to 50%.
Right, because when the primary engine fails, the downward spiral is incredibly rapid and difficult to reverse even with maximum intervention.
Okay, so we have an empty tank and a broken pump. What if the tank is full and the pump is squeezing perfectly, but the system still fails?
That brings us to obstructive shock. The failure is mechanical flow. Something outside the heart is physically barricading the blood from either entering or exiting the pump.
Like a physical kink in the hose?
Exactly. A prime example is cardiac tamponade. Blood or fluid rapidly accumulates in the pericardial sac surrounding the heart. This external pressure becomes so immense that the ventricles physically cannot expand during diastole to fill with blood.
Wow, so the pump works, the volume exists, but the fluid just cannot get in.
Precisely.
Yeah.
Which leaves us with the fourth and arguably most complex category, distributive shock. The tank is full, the pump is strong, there are no mechanical barricades. What breaks?
Afterload breaks.
Right. The pipes completely lose their vascular tone. It is a profound pathological vasodilation coupled with capillary leak. The blood vessels suddenly dilate to the size of storm drains.
So the heart can pump furiously, but without that vascular resistance, it can't generate enough pressure to force oxygenated blood deep into the tissue beds.
Correct. The most prevalent example globally is sepsis, which the sources note contributes to roughly 11 million deaths worldwide every year. An overwhelming infection triggers a systemic inflammatory cascade that essentially paralyzes the blood vessels.
And another critical distributive example is severe anaphylaxis, which is wild to me because I always thought of anaphylaxis as primarily an airway problem like your throat swells up, but it's actually a systemic vascular collapse.
It is textbook distributive shock. A severe allergic reaction triggers massive histamine release, which causes extreme vasodilation and sudden pulling of blood away from the central circulation.
Oh, okay.
This is exactly why epinephrine is the absolute first-line treatment for anaphylaxis. You need a powerful alpha-1 agonist to aggressively force those vessels to constrict immediately. Pumping a patient full of antihistamines won't reverse an active vascular collapse. It's too slow and doesn't address the acute loss of afterload.
That makes total sense. This breakdown of the variables, preload, pump, flow, and afterload, it completely changes how you view a patient at the bedside. Which brings us to a really fascinating section of the sources, the clinical counterintuitions.
Yes, the traps.
Right, because if you just blindly follow the textbook symptoms of shock, these different mechanisms will absolutely trick you. For instance, pop culture medical shows teach us that someone in shock is always pale, cold, and clammy.
And that physical presentation is very real, but it only applies to states with high systemic vascular resistance, specifically hypovolemic and cardiogenic shock. As the body frantically shunts blood away from the periphery to protect the core, the skin naturally becomes cold, pale, and sweaty.
But distributive shock breaks that rule entirely.
Completely. Because the underlying mechanism of distributive shock is pathological vasodilation. The vessels in the periphery are wide open. In the early stages of septic shock, the patient will often present with bounding pulses and skin that is flushed, pink, and warm to the touch.
Warm shock, that is terrifying. You could have a patient who feels feverish and warm, their skin looks perfectly pink, and they're actively dying of a cellular perfusion crisis.
Yeah, and if a clinician is anchored to the idea that shock always equals cold and clammy, they will miss early sepsis every time.
Here is another massive treatment trap I pulled from the sources. If we see a patient with crashing blood pressure, the universal instinct is to immediately hang a bag of IV fluids and open it wide. Push fluids to fix the pressure.
And 5E fluid resuscitation is the cornerstone treatment for hypovolemic shock.
Yeah.
It's also crucial in the early management of distributive shock to fill that dilated vascular space.
But if you misdiagnose the underlying mechanism, aggressive fluids can be lethal.
Oh, absolutely. Imagine treating cardiogenic shock with massive fluid boluses. The left ventricle is already failing. It cannot pump the volume it currently has. If you rapidly overload that failing pump with liters of saline, the fluid has nowhere to go but backward. It backs up into the pulmonary circulation, and you essentially drown the patient in their own bed by causing flash pulmonary edema.
And for obstructive shock, like the cardiac tamponade we discussed?
Pouring more volume into the tank does nothing to remove the mechanical barricade around the heart. That patient requires immediate mechanical decompression, like a needle pericardiocentesis, to physically drain the fluid from the sac.
Okay, I want to talk about my favorite physiological trap from the sources. We established that the body's primary defense against dropping cardiac output is a massive surge in sympathetic tone, driving the heart rate sky high. Tachycardia is the universal alarm bell for shock.
Right.
But there is a specific type of shock where the blood pressure drops, the patient crashes, and the heart rate actually slows down.
The bradycardic trick. It frequently catches students off guard on exams. This happens in neurogenic shock, which is a unique subcategory of distributive shock.
This typically follows a traumatic spinal cord injury, usually above the T6 level, right?
Correct. The physical severing of the spinal cord disrupts the descending sympathetic pathways. The brain is trying to send the panic signals, constrict the vessels, speed up the heart, but the connection is cut.
The sympathetic accelerator is totally disconnected.
Exactly. But the vagus nerve, which controls the parasympathetic brakes for the heart, doesn't travel down the spinal cord in the same way.
Oh, wow. So the vagus nerve remains perfectly intact.
Yes. So you are left with unopposed vagal tone. The blood vessels dilate, causing severe hypotension, and the heart, listening only to the vagus nerve, actually slows down.
Yeah.
You have a patient in profound circulatory collapse presenting with bradycardia. It completely contradicts the classic Sean presentation.
If you're waiting for the monitor to show a heart rate of 130 to diagnose shock, neurogenic shock will blindside you. It highlights exactly why you have to understand the specific physiological mechanism, not just memorize a checklist of symptoms.
And we are still refining our understanding of these mechanisms. The standard of care is constantly evolving as new data emerges.
Which brings us to the final piece of our deep dive, the moving targets in modern medicine. Even the most famous, universally taught protocols in this field are subject to fierce debate. If you talk about sepsis, you have to talk about Emmanuel Rivers and the 2001 early goal-directed therapy, or EGDT, trial.
The Rivers trial was a monumental paradigm shift. He implemented a very rigid, aggressive, step-by-step resuscitation bundle in the emergency department for the first 6 hours of septic shock.
And it involved placing central venous catheters to continuously monitor pressure, aggressive fluid pushes, blood transfusions, and specific inotropic drugs like dobutamine.
Right, and the results were staggering. In-hospital mortality dropped from 46.5% down to 30.5%. It literally rewrote hospital protocols overnight.
But then, looking at the sources, a decade later, 3 massive international trials in 2014 and 2015, Process, Arise, and Promise, they all attempted to validate EGDT, and they found that Rivers-specific complex protocol didn't actually improve survival compared to general standard critical care. Does that mean the entire medical community was wrong for over a decade?
So one of the most fascinating phenomena in clinical research, Rivers was not wrong.
Really?
Yeah, the consensus today is that his core underlying philosophy, recognize sepsis aggressively, give fluids immediately, and administer broad-spectrum antibiotics as fast as possible, was so successful and adopted so universally that it permanently raised the baseline standard of care across the world.
So by 2014, the control groups in these new trials were already receiving phenomenal rapid care that simply didn't exist in 2001.
We call it the usual care caught-up phenomenon. Rivers' complex protocol with the central lines and specific hemodynamic targets became obsolete, simply because his broader message completely revolutionized how the medical field approached sepsis. He forced the evolution of the standard.
That is an incredible legacy to leave on critical care. Another massive shift in the sources involves how we handle fluid resuscitation in the trauma bay for hypovolemic shock. For decades, the reflex was to pump massive volumes of crystalloid fluids, like normal saline, into bleeding patients to keep the blood pressure up.
And the logic seems sound on the surface, right? They are losing volume, so rapidly replace the volume.
But if you've ever wondered why paramedics and trauma surgeons don't just endlessly pump saline into gunshot victims anymore, the data from military medicine in Iraq and Afghanistan, alongside major civilian studies like the 2015 PRA-PPR trial, completely upended that practice.
We shifted entirely to damage control resuscitation. I mean, think about the physiology. If a patient is bleeding heavily, they are losing red blood cells, but they're also losing all their clotting factors.
Right.
If you rapidly pump liters of saline into their veins, you aren't giving them oxygen-carrying capacity. You are simply diluting whatever remaining clotting factors they have left.
So you are actively preventing their blood from clotting, making the hemorrhage worse.
Exactly. Trauma bays now utilize balanced blood products, aiming for a 1-to-1-to-1 ratio of packed red blood cells, fresh frozen plasma, and platelets, mimicking whole blood. Furthermore, they employ a strategy known as permissive hypotension.
Meaning they deliberately allow the patient's blood pressure to remain dangerously low.
Deliberately low, yes, until surgical control of the bleeding is achieved. Because if you have an unpatched hole in a major blood vessel, and you aggressively push fluids to drive the blood pressure back up to normal.
The increased hydrostatic pressure will literally blow the newly formed clot right off the wound.
Yes, you will pop the clot, and the patient will bleed to death faster. You maintain just enough pressure to keep the brain alive until the surgeon can clamp the artery.
It is such a high-stakes balancing act. Speaking of raising blood pressure, the sources also note a major shift in how we use vasopressors. The intense intravenous drugs used to artificially clamp down the blood vessels in shock.
Yeah, for a long time, there was a fierce debate between using dopamine versus norepinephrine as the first-line agent. But the landmark SOAP-2 trial in 2010 provided the definitive answer.
Right. The trial found that while overall mortality rates between the two drugs were similar, dopamine caused a significantly higher rate of dangerous cardiac arrhythmias.
Because dopamine acts on different adrenergic receptors in a way that highly stimulates the heart rate, causing those irregular rhythms. Because of that trial, norepinephrine is now universally recommended as the undisputed first-line vasopressor for distributive states like septic shock.
It is incredible how dynamic this field is. Let's take a step back and summarize the ground we've covered today. Shock is fundamentally a microscopic cellular perfusion crisis, not just a macroscopic blood pressure reading.
Right.
We've traced the evolution of the concept from the battlefields of the 1700s to the realization that oxygen delivery is the ultimate equation for survival. We've explored how breaking the variables of preload, pump flow, and afterload gives us hypovolemic, cardiogenic, obstructive, and distributive shock.
And most importantly, we've seen how clinical signs like warm, flushed skin or a paradoxical slow heart rate can completely mask a dying patient if you don't understand the underlying mechanics.
It demands an intense level of clinical vigilance and a deep understanding of cellular physiology. Now, to wrap up this deep dive, I want to leave you, our listener, with a final provocative thought from the expert side of the table.
We talked extensively about how the human body's compensatory mechanisms, massive vasoconstriction and tachycardia, are incredibly effective at hiding the signs of occult shock until the very last possible second. But how might the next generation of technology redefine that timeline?
Oh, that's interesting.
We are rapidly entering an era of continuous AI biometrics and highly advanced wearable tech. Imagine a continuous monitor, or even a smartwatch, that doesn't just read your pulse rate, but utilizes advanced sensors to detect the subtle, invisible shift to anaerobic metabolism and rising lactate levels hours before your vascular tone ever fails.
That would mean we could finally see the oil leak in the engine before the dashboard light ever needs to come on.
It would completely redefine critical care, transforming the golden hour of intervention into the golden day.
What an incredible thought to end on. Thank you for joining us on this deep dive. Keep questioning the dashboard lights and stay curious.